it's always good to look at optic disc swelling because you're always looking at discs. And aren't there a huge number of unusual optic nerves out there? And, there's the reality of that. You can't just send everybody in to come and have a check. So hopefully we'll cover some things that might help you in your day-to-day practice and some interesting cases. So I thought it might be quite good to have a little bit of interaction. So does somebody want to describe these discs? I heard you say yes, Penny. Yeah, so definitely blurred margins. So yeah, they certainly make you think, oh, these are swollen. And you might be familiar with Friesen grading. And I mean, I don't think you need to know about this, but it's something that I think is quite useful just in terms of, especially if you monitor discs on swollen discs on a regular basis, just to be able to have some grading scale. And so really it's top one is just swelling around the superior nasal inferior margins. And then grade 2, it's the whole 360 degrees. And then by the time you get to grade 3, you've got some vessels being obscured, probably the ones just leaving the optic nerve. Whereas grade 4, it's more severe. It's actually at the optic nerve. And then by the time you get to grade 5, you could be a complete newbie and realize that this is something unusual. So that's quite dramatic. And some of you may have recalled that I've talked about the terminology, and by implication, when you use the term papilloedema, it does imply that there's some pathology causing raised intracranial pressure. And most of the time it's bilateral, but it can be asymmetric. And so sometimes when you're not sure of the underlying cause, it's probably a little more accurate just to say these optic nerves are swollen. And then, of course, we're trying to differentiate from pseudopapilloedema. And there are lots of scary causes of papilloedema. And I must say that we don't see most of them. We would probably see a lot of patients with idiopathic intracranial hypertension, but many of these patients are actually quite unwell, and so they shouldn't really be turning up at an optometry practice. And I think, we've all been caring for somebody at some point in time in our lives. I think we'd be able to recognize that somebody's not right. You need to go straight to the 24-hour surgery, your GP or the emergency department. So what are some of the other causes of swollen discs that we might encounter commonly in day-to-day practice? Yep. Yeah, you can. Certainly, diabetic papillitis is a possibility. There's quite a list. But actually, even just anomalous discs, and I think we see that often. And sometimes they're obviously anomalous, and sometimes they actually look swollen, but they could be anomalous. And, usually like if you've got the CRVO and, all those sorts of things, you've got other features that will help you to differentiate. So how do we investigate papilloedema? Well, there's always egg on your face if you don't check somebody's blood pressure. So that's something that we would do when the patient comes through, because there'd be nothing more awful than to discover that somebody's picked up that they've got a raging blood pressure and we just hadn't recognized it. Usually you'd see other signs on the fundus. And, we look at the urine and looking for other systemic reasons. We do also look at the neuro-ophthalmic examination. And usually you shouldn't be getting other cranial nerves involved other than 6. You can, it's pretty rare. So if you get others, then we're starting to think about something else. But this is the stuff that you guys are really awesome at. And so you do it as a matter of you don't need to think about it. But I would say that disc images does not replace having a look at the discs. And often on my first assessment, I will dilate them because it gives me a really good look. But often they're also young patients and you don't have any issues with their media. So, it's as long as you can get a clear view, I think it doesn't replace fundal images. I've had certainly enough cases to say, compared to a previous photograph, these new photographs, it looks like there's disc swelling. And if you appreciate that just in terms of where you focus, it can make your photograph look quite different and even make you wonder if the disc has changed and is looking swollen now. And of course, by the time they get to us, once we've concluded that there is true swelling, we're looking at MRIs, and if the MRI is normal, then we're sending them on to the neurology service to have a lumbar puncture, and that measures the opening pressure, and they examine the CSF for any other abnormalities. Okay. So back to these discs, we've figured out that she is truly swollen. So to give you a little bit more information, she's 36 years of age, referred in by one of you, and for the last 6 to 9 months she's had what she describes very articulately as 3 different types of headaches. And I think that the one thing that I've really learned over the years is that you have to listen to the patient, because they know when something's not really right. So she says, I get migraines, but there's just something that's not right. I'm getting headaches after I exercise. I'm just generally, I've got frontal and parietal headaches. And she has gained some weight because she had a child 2.5 years ago. And what makes her weight gain even more tricky is that when she eats, her headache gets better. I'd be eating all the time if my headache got better. But the questions to ask: any transient visual obscurations? That's none. Do you know what is a typical symptom of a transient visual obscuration? So that's when people describe your vision blacking out or greying out, and it's usually quite brief. So it's differentiated from amaurosis, because amaurosis is usually longer. But transient visual obscurations are also something that people tend to experience if they've changed their position. So they've been lying down and they get up. So people describe it when they wake up in the morning, or when they've been sitting and they stand up and then suddenly go, everything goes black. Okay, so that's transient visual obscuration. She's got no horizontal diplopia, so looking for symptoms of a 6th nerve palsy. She's quite photophobic, and she's having some mild difficulties with her vision at work. And some more interesting history is that during her pregnancy, she had nausea and vomiting, which she just put down to being pregnant. And then at 30 weeks, she just stopped vomiting. But then she lost her sense of smell when she didn't have COVID. And her sense of smell hadn't returned. And she's a mild myope, so she's been to her optometrist regularly, and you can see that there's been a subtle change in her right visual acuity and a right RAPD, which is so key. So what do we do next? What test would you like? Did I hear someone say a visual field? So, I mean, I often find myself debating, should I do a 30-2, should I do a 24-2? And in my mind, 24-2 is something when I'm assessing optic nerves, but I don't know whether her pathology is optic nerve only, because it's bilateral swelling. So my starting point is this is neurological, right? So that's why I've taken her out to a 30-2. She doesn't have a typical homonymous pattern, but she certainly has significant visual field defect on the right and some on the left. And not surprising that she's got that RAPD on the right side. Okay, so it won't surprise you that her OCT RNFL looks like this. And you can just see that she's off the scale, and there's no colors in there because she's just way off the scale. So she landed up going to neurology to request an urgent MRI and MRV, and I actually rang the neurology registrar, which I don't usually, but I'll talk about fulminant IIH shortly. She just worried me, that she had visual field defect, she had RAPD, she'd been going for a while, and I must be honest, I thought, with the weight gain and everything, I was thinking that we were going to be dealing with another case of IIH, and I thought the next step after the normal MRI is that she's going to have a lumbar puncture, and then she got this. And so I think, in hindsight, all of those, the nausea and the vomiting, which she'd explained away with pregnancy, and, all the other headaches that were new, and this is in her olfactory groove, so no surprises that she lost her sense of smell. So she actually got referred to the neurosurgeons, had surgery, and fortunately, now lives happily ever after, because you can see how the disc swelling is resolved and her RAPD's gone and her OCT, this is July when she presented, and being a high myope, we might kind of go, okay, the superior quadrants could be just her optic nerves and her visual fields. So quite a remarkable case. It wasn't what I was expecting, but it just goes to demonstrate you need to get that MRI. And she's not the kind of case that I would have written to the neurology department and go, could you please see so and so, and then wait for them to triage. And you can see there's concerning visual signs, visual dysfunction. She needs to be seen sooner than just in due course. Okay, we've got another case. So I would say, so everybody's looking at this going, yep, swollen discs. And I can't fault you for that, because that's what I would conclude as well. And again, just to reiterate, you've got to look at them on the slit lamp because it is really tricky. But there's no doubt that he had elevated discs and obscuration of all the margins. You can't really see the cup. Are the blood vessels obscured? Really hard to tell. So, swollen discs, papilloedema, hard to know. So you want to know more from the history. So he's a 17-year-old. He went to see his optometrist because his vision was blurry, and they managed to correct him up fully. He's a mild myope, and he's got no optic nerve dysfunction, normal visual fields, normal color vision, no RAPD. He's well. He's a 17-year-old, active, healthy, BMI is normal, and he's not on any medication. So we're at this point now where we're trying to go, is this pseudo swelling or is it true swelling? So what are some of the clinical features that might help us make this distinction? Any volunteers? How about just the history before you even get to examining the patient? Yeah, awesome. So you need to have all of these, right? You need to have an explanation for why their vision's blurred. If you don't, you've got to think twice. No symptoms, as you said, Penny. So no transient visual loss, no pulsatile tinnitus. You want the testing, normal color vision, normal perimetry. These days is very, I don't think I've ever done a fluorescein angiogram because we've got other ways to figure it out. But in the old days when we were doing FFAs, you'd see some leaking if there was true swelling. But nowadays we were more inclined to use ultrasound or autofluorescence, which can be really helpful. But the features on the other side of the slide, I think they're really good if you put them into clinical practice. So I'm going to go through them tediously, one at a time, because I think if you take nothing away from this talk and only this slide, this is the thing that's going to help you in your day-to-day practice. So is the disc just unusual? Is it small? Is the cup small? Is the cup absent? Or is the disc tilted? And then you want to have a look at your nerve fiber layer over the disc, because if there's swelling, which actually looks like an opaque nerve fiber layer, it will obscure the disc vessels. Right. And as you saw on the Friesen scale, you could either just be obscuring the vessels beyond the disc, or if it's severe, on the disc itself. What color is the disc? Okay, so it shouldn't be hyperemic. If it is hyperemic, you're thinking there's pathology. Right. And you also want to see that the area of the disc elevation, if it's pseudo swelling, it's confined to the disc. It doesn't spread beyond into the peripapillary retina, because that suggests pathology. And there's one thing that I sometimes forget to look for, is that circumpapillary light reflex. Now, you don't see it always, but if it is there, it's quite a reassuring sign. And it is lost in true swelling. So here's some examples of disc autofluorescence. This is this patient that had the 17-year-old. there's possibly a spot up on the supratemporal aspect of the right nerve, but the left nerve, there's nothing dramatic. I mean, this is one of the most dramatic cases of drusen, and you can just see how you don't even need the fundus autofluorescence to see those drusen. But it's not usually as obvious as that. These are some other clinical features that are quite useful. So when you look at a case of pseudodrusen, you often see an unusual pattern of branching from the blood, from the disc. And the other thing about hemorrhages is that if they're subretinal, then they're probably not anything concerning. But if you see flame-shaped hemorrhages, that signifies pathology. Okay, so that's quite a good useful sign. Now, spontaneous venous pulsations has historically been described as something that's quite useful to rule out issues with raised intracranial pressure. But more and more people have recognized that it's actually not that helpful because there can be variations in intracranial pressure. So, you know, it's not a very reliable sign. So I think more and more we're going away from the fact that, you know, just because you see it, it doesn't protect you from having swelling. So I don't really pay much attention to that. Okay, so back to our 17-year-old. These are his visual fields. Nothing too dramatic. I mean, he's got a little bit of infranasal patch there on the right field. And these are his OCT RNFL. So not like our first case, our 36-year-old, where, you know, she was completely off the scale. But you can certainly see that, especially on the left side, the one that's on the dotted line on the RNFL thickness, that he's off the chart. So quite a tough case, isn't it? You're kind of going, oh, is this asymmetric true swelling? He doesn't really fit the picture because he's got no clinical signs, and yeah, but so sometimes they can be really difficult. And to be quite honest, when I looked at that nerve, those optic nerves, I couldn't be 100% sure that it was pseudo. I mean, all the clinical signs points to pseudo papilloedema or pseudo swelling, but I just, yeah. Anyway, so I landed up getting an MRI, and thankfully it was normal, and the parents were immensely relieved. And the other thing that we look for is venous sinus thrombosis. So, you know, sometimes it is just, you just have to get an MRI. The question then is, okay, are these swollen? And he's got a normal MRI. What next? You know, do I now send him to the neurologist and send him for a lumbar puncture? And it is a dilemma, but based on his lack of concerning neurological findings, I decided to watch him. And this is where the OCT RNFL GPA can be so helpful, because, you know, I've got time on my side. He's well, so I got him to come back serially, and so every 4 weeks, and, you know, with the advice, if you become unwell any way, vision symptoms, come to me. You know, systemic symptoms, go to see your GP. If you get really bad, then please go to the emergency department. But it is quite comforting to see that over the 2 or 3 months that I was monitoring him, you can see those plots are virtually identical. And so he's not, you know, he doesn't need to go for a lumbar puncture. And, you know, this patient came from a colleague, and he'd gone down the whole route of, oh, yeah, you've got swollen discs, and had a lumbar puncture. And in the end, it just turned out that he had drusen. So, you know, these cases can be really tricky. Okay, moving on. 33-year-old came to see one of you guys, and you want to know more, don't you? Because, well, let's just pause here for a moment. Any takers? Anybody want to describe these optic nerves? Yep. So the superior nasal inferior margin, more on the right, but even on the left, is quite obscured. You can still see the temporal margin. So, yep, I would go along with that, Penny. I'd go, yep, maybe these are tilted. And it's quite nice to know that she's got no visual symptoms, no neurological symptoms, no transient visual obscurations, no pulsatile tinnitus. Do you know what that is? So the way patients won't say, I've got pulsatile tinnitus. They'll just go, I've got this whooshing noise. And so is that just normal tinnitus? Or so what I usually ask them is, can you hear your pulse? Can you hear a rhythmic whooshing noise? And it literally sounds like whew, whew, whew. And sometimes you can hear it, but nothing, you don't ever take anything in isolation. So if you've got that symptom and you've got other things to be worried about, then you're starting to pay attention to it. She's got normal vision, RAPD, colour vision is normal, and she's not overweight. But what's this? Anybody know what those folds are called? Anybody heard of Peyton's lines or folds? So described way back, even in 1911, by Peyton and Holmes, and it can be a helpful sign of pathological optic disc edema, even today. So, these are cases where they knew that there was swollen discs for whatever reason, and they just were observing these peripapillary folds. So I think it's quite a useful thing to tune into. So it did make me stop and pause, and here's this patient's visual field. She's got a defect, but she's well. So went on then to get an OCT. Not a dramatic degree of RNFL thickness. She's a little bit out of the scale, but not hugely so. And so, sometimes even in private, patients aren't fully insured and they don't have radiology cover. And so I always have this conversation, these are my thoughts and I share with them. This could be swollen nerves, which is a reflection of something going on in your brain. And then I give them the option. And then I also say to them, but I'm also reassured by these clinical findings that you don't have anything worrying. So we've got these choices. One is, if you want to have an MRI, and there are some people who are not privately insured, but they're willing to pay for it. You've got that option. Or the other option is that we have time, we can afford to watch, and we do have time. Okay. So comforting to see here that her right and left RNFL, you can see the little purple area that's highlighted and the little orange area that's highlighted. I don't think that's significant. So watched her and she remained well and she's clinically well. So in the end, we didn't do anything. And I discharged her, and so I think she just got anomalous discs. So here's another, happened to be a 33-year-old, different case, and she comes in with these discs with these patterns folds, and but she's got no symptoms, no neurological symptoms, and her visual fields are normal. And so then you kind of go, these are supposed to be a sign of true swelling. And so we get an OCT, and this is even more comforting because she's actually not showing significant RNFL thickness. But, again, have the same conversation, and she was insured and she was really keen to know. And so we did an MRI and an MRV, and it was normal. And her disc appearance hasn't changed. So although Patton's folds are supposed to be a sign of concern, here's two cases where, at the end of the day, it's all about putting the clinical picture together. Okay, moving on. We've got a 31-year-old. This is pretty dramatic, isn't it? Now, the reason why these photographs look so unusual is because this is done on the old style photographs. And there's no doubt that, and even clinically, you could just see there's lots of elevation and she's got florid swelling. So you want to know more history. Well, she went to see one of you guys because she had blurred vision, and she'd been getting frontal headaches. They were getting worse to the point where she was struggling to function during the day, and she was hearing this whooshing noise, this rhythmic whooshing noise. So that's pulsatile tinnitus. And then she said, when I wake up in the mornings, my vision's black for about 5 to 10 seconds, and then it comes right. It's typical TVOs. She had no diplopia. She was neurologically well. you always want to know, are they pregnant? But she had been struggling to fall pregnant. She probably could give Valerie Adams a good run for her money. So she's a big lady, not on any medication, and she'd been having lots of issues with endometriosis. Vision was a bit down on the left side, but her optic nerve function was still pretty good. And even though I was quite sure about the swelling here, and interestingly, her blood pressure was quite elevated, but I don't think was the reason for her disc swelling. She just had a separate issue. But it's good to know. And here you can see what's the most striking feature of the visual field on the right side. Yeah, so for sure. So I gave a talk to the registrars the other day, and I quizzed them because to be honest, I don't know that I really ever got taught what is a normal blind spot size. Anybody? 7.5 degrees vertically, 5.5 horizontally, and it sits between 12 to 15 degrees temporal to your point of fixation, and 1.5 degrees slightly below the horizontal meridian. So it's kind of nice to sort of have that, in your mind, because when you know what normal is, you know what abnormal is. And here it's pretty obvious. And look at these OCTs. She's gone off the scale too. There's no doubt in your mind that she's swollen. So how are we going to investigate her? She had an urgent MRI and MRV. And it's interesting because when you read, textbooks and articles, they're written in countries where they have an abundance of access to healthcare. And we don't live in that kind of environment. And they all put the fear of God in you, and they say you need to get an MRI within 24 hours, and we just can't. So I think for us, whilst that would be ideal, we often have to use some clinical judgment to give the radiology service some kind of indication as to how urgently we need the investigation. But anyway, not surprisingly, she had distension around her optic nerve sheets and flattening of the optic discs, which are radiological features associated with raised intracranial pressure. And then she went on to have a lumbar puncture, and the normal opening pressure is about 25 centimeters of CSF, and hers is significantly elevated. Her CSF went off for testing, and it was found to be normal. But people can have quite an unhappy experience after lumbar punctures. They're not the nicest things. And so I'm always mindful of who am I going to refer for a lumbar puncture. And she had a miserable 3 to 4 days afterwards and needed a blood patch, and even Lana being admitted. And I recently came across this article, which is just a whole focusing on IIH, and it gives us some really useful clinical guidelines. But essentially, it's a flowchart of what I've been talking about. So what's the diagnosis here? IIH. Okay. So just a little historical note. I just find it amazing that even back in the 1890s, somebody was describing it. And then, the terms serous meningitis, and then as we grew to understand the condition, pseudotumor, and then Dandy, who even came up with the classification system, talked about raised pressure without tumor. And then in the 1950s, there was the use of benign intracranial hypertension, but I really strongly recommend that we avoid that term because, as you'll see in some cases, it's not a benign condition, and that just implies that, we can just chill, we don't have to worry about it, which is not the case. So now we're using the term IIH, Idiopathic Intracranial Hypertension, but it's also good to remember that there are secondary forms of raised intracranial pressure, which is not idiopathic. So, as we're managing IIH, we're thinking about these things, who gets it, and if we know who's typical, then we know who's atypical. In the atypical cases, we just need to think twice about it before we label them as IIH. So it's good for us to know about the symptoms, good for us to know about the secondary causes so that we might be able to address those issues. And, we talked about the way we investigate, and then we'll get to how do we treat and follow them up. So in terms of diagnostic criteria, typically people have papilloedema. They need to have a normal neurological examination, and other than your 6th cranial nerve palsy. And on neuroimaging, it's normal, including you can't have hydrocephalus, because if you have hydrocephalus, if you have raised intracranial pressure, it can result in hydrocephalus, but there's some other pathology going on, so you can't have hydrocephalus. Your meninges need to be quiet. You can't have a structural lesion, and you can't have venous sinus thrombosis. And we talked about raised pressure, and your CSF needs to be normal. So those are the criteria that you need to have to make the diagnosis of IIH. Who gets it? Predominantly women of childbearing age. And sometimes it's quite useful. I mean, it's always a delicate topic, isn't it, to ask a woman how much she weighs. But I think it's quite good for clinical documentation, because you get an idea of how the patient's struggling. So I think it's just one of those things that to remind us to document. And then what's atypical is if you're not female, because men can get IIH, not of childbearing age. And I've seen women in their 50s who had it once upon a time and it was all quiet and gone away for a long time, and then they went through a patch for whatever reason, gained weight, and they got their IIH back. If you're not overweight, you need to wonder about it and investigate more appropriately. So it's interesting that you can also get asymmetric cases, which is a little hard to kind of figure out, but everybody has variations in anatomy. So, I saw this lady in 2019, and she just had one side that was swollen, and you can kind of make out she's actually got a flame-shaped hemorrhage nasally on that disc. And the left side was what you describe as normal. But she went through all the investigations. MRI was normal, lumbar puncture, elevated CSF pressure. So she was diagnosed as IIH, and you can see how, after the appropriate treatment, her swelling improved, and she's being monitored. So what are the typical symptoms? We've been talking about these symptoms. Anybody want to recap for us? Yep. So they might notice some problems with their vision. Yeah. Pardon? Yeah, headaches for sure. Yeah. Anybody else? What was your lady having, Paul?
Just a few visual sensations, really.
Okay. Yeah.
And fatigue.
Yeah. Okay. All right. So a lot of these patients have lots of different types of headaches, but they often describe as the headaches that they've had are getting worse. And then we've talked about vision symptoms, the TVOs, horizontal diplopia, pulsatile tinnitus, and then a number of symptoms that can be quite vague, back pain, bit of dizziness. They just don't feel so sharp in their brain. And the key thing is none of these are pathognomonic for IIH. So then it can be quite tricky. So as usual, it's a constellation of clinical features that you put together. So as I was saying that, many of these patients, they have other primary headache disorders, which, they might have suffered from migraines for years. But usually they come and see you guys because they go, my vision, plus or minus, got symptoms, but my headaches are really getting worse and more frequent. And so, like I said, we do need to think about other causes of raised intracranial pressure, and there's a whole host, and I'll show you some overwhelming tables in a moment. But in a nutshell, you look for systemic disorders. Do they have any medical history, any endocrine conditions, any syndromes, anemia? So, we'll be sending them for a blood count, and are they taking any medication? So this is from the same paper. This is the first part of the table. So you can see there's a whole list of, and cerebral venous sinus thrombosis, come across that occasionally. But a lot of the other things they don't come to us for. Here's a list of medications that, interestingly, it's steroid withdrawal. Now, I've never seen a case, but, people talk about it. And so, yeah, it's useful to go through a list of medication and just check that they're not on one of those. And they're not being put on one of those recently, because I think, you can be on these medications for a long time, and then you got to wonder, is it really that medication that's caused it? These are some of the systemic disorders, renal issues, endocrine issues, and some of the syndromes. And over the years, you come across these questions, and it's not uncommon for the patient to be a woman who's on some kind of contraception, and then the question is, well, should I be stopping my contraception? And there's not a lot of information in the literature, but I think chatting to people who've been in practice and looking up whatever is there, I don't think we can blame the hormonal contraception unless they were recently started on it. And the other thing is that, medications that are associated with causing raised intracranial pressure, is it okay to put them on it, for whatever other medical condition they present with? And there is no clear evidence that it's contraindicated. So this is just about lumbar puncture, and there's quite a wide variation in pressures, and you can also get false readings, because if the person that's done the lumbar puncture has had a hard time finding the right spot, then you might find that they would have entered and then not realize that they were in, and they would have had a trickle out. And then actually when they finally find the space to measure the pressure, you're not actually getting a true reading. So, I've had a case where the poor lady said that they just poked me so many times and the pressure was normal, but she had all the other features that fitted with the IAH. So we just came to the conclusion, not sending you for another lumbar puncture, but we're going to treat you as if, and she did well. So, as you can see from the table down the bottom, the higher your opening pressure, the more likely it is. But it's not to say that if you're in the lower end of the scale that you can't have it. It's just you've got to take a number of things into consideration. I learned something, and that you can actually get IAH without papilloedema. Now, it is a rare subtype, and in my mind, it's kind of not something that I would get too stressed about, because the thing is, if your nerves aren't swollen, from our point of view, you're not going to have any vision problems, so, but it is a thing. So management principles, and you can see there's a whole team approach, and you guys are often at the starting end of it because you're the ones that pick it up and refer them in, but they can present in, to any of those specialties, and then we see them, we liaise with neurology, we need the radiologists, and what we don't do very well is we need to support these people, because they need a whole network of nurses, dietitians, personal trainers to get them through this patch where they can actually lose some weight, and occasionally we need to call on the neurosurgeons. So the principles of management is, first of all, to treat the underlying disease, second of all, to protect their vision, and thirdly, to minimize the headache morbidity, because it can be considerable. And one of the key things which the paper didn't say, but just from my personal experience, is that it's so critical that we determine the acuity. In other words, not visual acuity, but how urgent these patients need to be seen. So, here's the whole series and the flow chart. But the fulminant IIH is something to tune into. Now, you won't come across these cases often, but, it is just tragic. Here's a young girl with the most florid swelling on her optic nerves, and she's been presenting, and people have not been taking her seriously, and her vision plummets within weeks. And they just know that something's not right, and we can also tell that. So if you see somebody with those discs, and they usually have worrying visual fields, those patients are urgent. They need to be seen urgently. They need their MRI within 24 hours. They need attention ASAP. And this is definitely an example of why it's not a benign condition. And here, the management is surgical, and they need to have some kind of procedure, usually a shunt. there isn't really anybody that does optic nerve sheath fenestration, but that's not really appropriate if you've got bilateral papilloedema. And, sure, there are shunt complications, but, if you're talking about saving someone's vision, to me it's a no-brainer. Fortunately, there's not that many cases, but it is tragic when we miss these cases and they don't get the attention that they need. There is neurovascular stenting that's been discussed, but I don't think it's mainstream at the moment, so I just mention it for completeness. Around the world, people do optic nerve sheath fenestration surgery, which certainly has less complications generally than CSF diversion, but it's not going to help you if you have bilateral involvement. And there are some associated complications, and then there's also treatment failure issues, so it's not something that we do in New Zealand. And this is tragic case. Her optic nerves, this is her 5 weeks later. So you can see it doesn't really take much to go from florid swelling to this. And in the meantime, she just got her shunt too late. I mean, it's fair to say that sometimes we don't win. Sometimes they get picked up early enough and they get the right treatment, and they just got really unlucky to have fulminant IIH. So what's the pathogenesis? I mean, it's fair to say that we don't really understand this condition very well. And because we don't understand it, we don't really know how to treat it. So this paper canvassed a consensus from practitioners around the UK, and also leaned on an international panel of experts. And there's basically two things that we focus on, and they're happening simultaneously. One is to encourage people to lose weight, and second is Dimox. And weight loss, it's people have gotten to this point and they've all got complex backgrounds, and it's a very difficult situation that they're in, and it's definitely something that has to be dealt with some sensitivity and compassion. We don't really know what's the right amount of weight for people to lose, and I try to really encourage people to, one, be kind to themselves. You'd just be astounded at, there's so much complexity that these people are dealing with. How many people break down in tears when I just say to them, you've got to be kind to yourself. And I try to really encourage them to make sustainable changes, even if it is just cutting out the fizzy sweet drinks. That's, an amazing starting point. But, they've got to attack it from multiple angles. It's diet, it's exercise, it's lifestyle, it's habit, and they've got to get support from wherever it's the family that's going to help them, because if everybody is sitting around the table drinking your sweet fizzy drink, and it kind of makes it really hard for you to not be the one participating in that. So it's not just the family, professional help. I don't know if anybody's aware of the green prescription. So that's something that we can fill in online for them as practitioners, and they get some discounts for city council facilities. So that might help them to be active as well. And I've had a few patients who have leaned on bariatric surgery. So there are only 2 randomized control trials on IIH, which is quite astounding. And one showed that there was significant benefit in using Dimox, acetazolamide, compared to diet alone. And there was another that showed there was no effect from acetazolamide. And a Cochrane review said, well, there seems to be some modest benefit, but we just don't have enough evidence. So we are still in this position where we lean on acetazolamide whilst we're trying to encourage them to lose weight. 4 grams a day is a maximum dose. That's a whopping dose. You will just not be happy on 4 grams. They have so many GI symptoms. They're nauseated. It saps your energy. Who feels like exercising when you feel like that? You just feel tired. Remember that this is a childbearing age group, so there are teratogenic risks as well. So I usually start them on a small dose and I titrate them up. And I just say to them, build yourself up slowly to get to the point where you've got side effects. And then if you can stick with that for a little bit, and sometimes they can gauge if their headache's better, they're getting less TVOs, they're getting less visual symptoms. That can sometimes be helpful, but not always. And then of course the monitoring. There are other drugs that we can use. Topiramate is sometimes used. but there are, I find, more side effects. One of the advantages of topiramate is that it can be used as a treatment for headaches, migraines, and it does tend to suppress appetite as well. And people have been on other treatments. So monitoring, I mean, we do this every day, so that's not difficult. But I think, what that table shows, and I would highlight the red area, is that the severe, they're affected and worsening. I mean, I would even say that 1 week is a bit too long. I mean, those sorts of patients I'm almost checking every day until I have got the attention of some neurosurgeon to make sure that they're getting the appropriate treatment. So our 31-year-old, she really made a concerted effort to lose weight. She changed her jobs. She recognized that her work was just not conducive to a good lifestyle, that she could look after herself. And she was on Diamox, and you can see how her optic nerve swelling came right down. And again, here's a really nice way to demonstrate the utility of an OCT. So she tolerated her side effects, and her symptoms improved. So she had less pulsatile tinnitus, less transient visual obscurations. She still was getting some headaches, and that's not uncommon. But like I said, she changed her job. She was becoming more active, and she put her fertility plans on hold. And you can see how her visual fields were then and improved. So by this stage, she'd lost 9 kilograms, and she was gradually reducing her Diamox. But then in October, later that year, she came back. She's now ecstatic because she's 7 weeks pregnant, very precious pregnancy. But she started recognizing that she was getting transient visual obscurations in the last month. Interestingly, no headache. So, I don't get that. But anyway, vision was still good, but her nerves were swollen again. So I sent her along to the neurologist. I find it interesting that they did another lumbar puncture. But anyway, I guess it confirmed that she had raised pressure again. And you can see that now she started to worry me. Because here she is, 6th of December. Vision's still good, but she's got a significant visual field defect on the left. And then a week later. And then we've got that surprise event called Christmas coming up. And, you can see how things have changed. And again, how the OCT is really helpful. From May, when she really resolved, all the swelling had gone, to December, you can see her RNFL thickness has increased. And I was going away, and I was really worried about her. So I put in all the belt and braces kind of backup plan, rang the neurosurgeon and said, look, who's on call over Christmas, because you might see this lady coming through. And I put the fear of God in her and said to her, if you're getting worse, do not sit on it. Go to the emergency department. And it's a dilemma because, she's 7 weeks pregnant. It's a precious pregnancy. I mean, every pregnancy is a precious pregnancy, but, you can't give her Diamox. She's in her first trimester. And so what are our options? Do we shunt her? She's not excited about having any more lumbar punctures, but the literature does talk about serial lumbar punctures, and it has a limited role, but this might have been one of them. And I put a plan in place, got her to come for a review with a colleague, and then I came back in early January. What's happened to her? And she DNA'd, and I was like, oh. So she'd had family bereavement in the meantime, and she'd had health insurance issues, so she didn't come to her appointment, and I was just like... Anyway, so I saw her at the end of January, and her nerves were as swollen as ever, and she'd had symptoms, and thank goodness her visual fields were stable. And then another month later, and here's a lady who her pregnancy is so precious, and I totally get this. I'm happy to go blind in one eye. I just want this baby to be good, and it's a big call, isn't it? But anyway, she stabilized, and now we're out of the first trimester. So then we started to have conversations about, well, okay, we could put you on Diamox. I am still worried about your vision. The risk to the fetus is a considerable consideration, but so is you going blind. And so then you have to kind of tap into other sources of advice, and you get the obstetricians and clinical pharmacology assessments. And Diamox is used out of the first trimester, so that's what we did. And thankfully, and all the other things like, I mean, it's hard not to gain weight when you're pregnant. It's just that you want to gain an appropriate amount, and monitoring her. And if there was any imminent risk to her vision, we'd be going down the route of looking for a surgical solution. And like I said, there's a limited role for serial LPs, but of course, nobody likes the idea of having a needle stuck in their back, and it isn't without a small amount of risk and issues with back pain. And I'm happy to tell you that this lady lives happily ever after for the moment. Her visual field stabilized, and her disc swelling resolved. She had a baby. She's actually had a second baby, and fell pregnant without needing IVF, and the second baby, she didn't have any issues with IIH. So that's a happy ending. These patients do suffer a lot with headaches, and there's so much to cover from an ophthalmic point of view. I do lean on the GPs to address this because there's lots of different types of headaches that they can have. But there is a concept of overuse of medication. So, people that are using simple analgesia like paracetamol and some non-steroidal regularly, more than half of the month, or opioids more than 10 days a month for 3 months consecutively. I think, that's an idea and it's quite a hard one to sell because you've got to get them off their treatment so that you can almost kind of get to a baseline again. And you can tell that, it's almost a consultation on its own. Acetazolamide isn't always effective to help treat headaches. So, you do have to tap into your GPs. And, as I mentioned, it's not uncommon that people have lots of different types of headaches. They could be migraine, tension type, and you can have headaches related to your CSF pressure if it's too low or too high. And even, for headaches, I think we do lean on medication. We don't tend to lean on a surgical solution to manage headaches. We tend to reserve that more for if your vision is starting to plummet. And I mentioned neurovascular stenting, definitely not for headaches. It's still, the jury's out there for where it is indicated. And then we do find ourselves in slightly tricky situations sometimes where, you have someone with known IIH, and if the pressure's gone up again, they might have papilloedema. And then what becomes even trickier is if you have atrophic optic nerves and they can't get swollen, and you don't know what's happening to their pressure. So sometimes you might have to do some pressure monitoring or repeat the lumbar puncture. But generally speaking, if there's no papilloedema or there's no imminent risk to vision, we don't think about shunt revision. And nowadays they've got these clever devices on, they can put a valve on their shunt, so even those things can be incredibly helpful. But that's the realm of the neurosurgeons. So I think it's just something for us to be mindful of, that there are lots of other associated issues with IIH, and these people need support. They've got often complexities going on behind the scenes. And so just to recap, the management principles, and also to recognize the fulminant. It's rare, but it really needs to be recognized because it's so tragic when you have a young woman who's gone from having good vision and in a space of 2 weeks has lost so much vision permanently. So who's brave enough to recap for us how to differentiate true swelling from pseudo swelling? We're almost there, I think. Actually, we've done very well. I was trying to get 60 slides, and we're on 95 out of 96 slides, so we're almost there. Okay. So remember, they shouldn't have blurred vision that you can't explain. You don't want them to have any symptoms. You want their vision to be normal, no colour vision issues, unless of course they've got congenital deficit, normal visual fields, and then remember to scrutinise those discs and think about these features. Are the discs abnormal, small? Is the cup small, absent? Are they tilted? Look at the nerve fibre layer, see if there's any obscuration or opacification suggesting swelling. What's the colour of the disc? Is it more hyperemic? Where the disc is elevated, is it confined to the margins? It's more likely to be anomalous. Or has it spread beyond that into the peripapillary retina? And I have to remind myself as well to tune into the circumpapillary light reflex, because it can be quite a useful sign. So well done for staying awake. And thank you for coming. It's really nice to see you in person. And hopefully we'll be able to continue and host these now on a regular basis, that COVID is not going to be a barrier. Yeah. Question?
You say you want to exclude malignant hypertension as a cause.
Mm-hmm.
Wouldn't you be seeing widespread hemorrhages?
Yes, absolutely, yeah. So that's why I usually say, you don't usually see just disc swelling on its own, which is why what happened in that case where all she had was disc swelling and the rest of the fundus had nothing else. And that's why I was confident that even though her blood pressure was elevated, and not insignificantly elevated, that I didn't think it was the blood pressure that was causing that. Yeah, but you're quite right. You expect to see a lot more other features. Yeah. Anybody else? No questions? Yeah. So hopefully that was useful for clinical practice day to day. Yeah. So feel free to stay and chat, because you might quite like to catch up with your colleagues, and I'll come and mingle. And I don't know if there's any food left, and have some drinks. Yeah. So thanks for coming.
Cheers.